Hello, hello, it's Professor White, and the topic of this video is going to be urinary tract infection. Of course, we will be going through this under next-gen NCLEX standards, so we're going to recognize and analyze cues, which includes assessing the patient, reviewing the chart, considering the patient, their values, figuring out what's relevant from what's irrelevant, what information may be in the past medical history and may be important, risk factors, analysis. We're going to prioritize hypothesis, where we look at the most pressing concerns. These would be possibilities, priorities, risks related to the solution to the problem, and also risks if we don't solve the problem. Generating solutions and taking action, that's the old part of the nursing process of planning, implementation, and evaluation. So we're going to make patient goals, expected outcomes, implement our plan using the skills, procedures, collaboration, teaching, ethical considerations, and evaluate how well things work. And then, of course, medications to know. All right, so let's dive right into here today with urinary tract infections. Urinary tract infections are among one of the most common things that you will be dealing with as a nurse, especially with an aging population. But it is an infection of the urinary tract, and it can be any site along the urinary tract. It could be the upper urinary tract down through the lower urinary tract. And we'll begin to look at the different signs and symptoms based on where the infection is. The most common cause is E. coli, and that makes sense, right? Because E. coli is a common flora that's found in the colon, and colon and urethra are very close together, especially among females. So women are going to be more likely to have E. coli. So 75% of uncomplicated UTIs are caused by E. coli, and 65% of complicated UTIs. And so what's complicated versus uncomplicated? Right, so uncomplicated means that it's the bladder only, and complicated is it could be a person with underlying health issues, any sort of structural abnormality, somebody who's immunocompromised, anybody who's pregnant, or if it's a recurrent infection. So upper UTI versus lower. The upper would be things like pyelonephritis, and then into the lower would be, bladder storage. So it's whether it's bladder making, bladder transport, bladder storage, or bladder evacuation. Or I'm saying, when I said bladder, I really meant to say urine. So urine production, urine transport, urine storage, or urine elimination. And based on where along the urinary tract the infection is the signs and symptoms that you're going to see among a patient. For a lower UTI, because that's where we have emptying and storage, you seem to have those symptoms, right? Emptying symptoms, storage symptoms, frequency, dysuria. Upper UTIs, that's where we're going to see problems with the kidneys and in those areas, so flank pain, chills, fever. Urethritis is a common complaint. Urethritis is not seen just only in UTIs, but also with some sexually transmitted infections. So like trichomonas, chlamydia, gonorrhea. So I just want you to bear that in mind. So who's our exemplar patient? It's going to be an older adult postmenopausal lady. Okay, that's going to be your most common UTI sufferer. Sometimes the patient complains of dysuria, that's painful urination. So some other things that we would have to consider is that UTIs are the most common healthcare acquired infection that's out there. And as a nurse working in a hospital, you're going to be spending a lot of time on things called CAUTI bundles, catheter-associated UTI bundles. So basically, those techniques and policies, procedures that we use to prevent catheter-associated UTIs in the hospital. We do have some normal things that help us avoid UTIs. when we go to the bathroom and we micturate, right? When we empty our bladder, we void to completely empty the bladder because that gets rid of stagnant urine. Our urine is slightly acidic, and we have some antimicrobial proteins also present. So anything that changes the anatomic structure or the ability for the bladder to completely empty, anything like that can absolutely lead to increase in UTI risk. Most organisms that do enter the urinary tract infection do not come from the body out. They come from the urethra up in. And having medical equipment like Foley catheters is a big risk factor for that. So somebody who already has a medical device in their urethra would be at high risk for a UTI. Sexual activity is also a risk factor, not just for urethritis and STIs, but the friction and basically it can cause a translocation of bacteria as well. So we do encourage people to avoid after sexual intercourse and anybody with a compromised immune system, because that alone can make it hard for the body to normally purge itself of the bacteria. So when we look at signs and symptoms, please be aware that clinical manifestations, these signs and symptoms, may be absent in older adults, right? An older adult, elderly person is more likely to complain of generalized abdominal pain. They'll have cognitive dysfunction or just a general deterioration. They might be confused, disoriented, where normally they're not, lethargic when normally they're not. So it's going to be a change in their baseline behavior. Lower UTI symptoms, so storing and empty, these are the signs and symptoms we already mentioned, but bears mentioning again. Dysuria, frequency, urgency, discomfort in the suprapubic region, and then changes in the urine itself, right? Urine may be cloudy, have an odor, may have some frank hematuria, could have sediment in it. But you don't have a ton of constitutional symptoms. But once that UTI moves up the urinary tract, then you end up with a lot more symptoms as far as like fever and chills. So how do we diagnose a UTI? Seems pretty simple, right? Check the UA. So a UA and a culture. What are we looking for in a urinalysis? What tells us that we have a potential UTI? Now, it's not going to tell us the actual organism, but it's going to tell us something's in there. Urinalysis would show nitrates, white blood cells, leukocyte, esterase. So if you have that, as a nurse, your responsibility is to report that off to the doctor as presumptive positive UTI. They may want to start antibiotic and not wait 2-3 days for the cultures to come back. So culture and sensitivity, clean catch is the preferred method. And a little pet peeve for me, guys, when you get a urine culture, if it doesn't tell you how it's captured, make sure you write somewhere on there how you did it, because if you have a Foley catheter and you get a urine sample from the catheter, that urine should be absolutely sterile. There should be no organisms in it. However, a clean catch can have some organisms, especially skin flora. So it's very important for the lab to know these things, right? If I have a Foley catheter sample, I would expect 0 bacteria. So if I have any bacteria, that's a problem. So just make sure you look at that when you're doing that. Sensitivity tells us what antibiotics can potentially treat this infection if there's any bacteria that's isolated. And that takes a little longer. We get the urinalysis, we get the culture, and then the sensitivity. And remember, with our urinalysis, check their meds. Some meds can give a false positive with their protein. So they can make protein spill into the urine. So if you're seeing that, just, take a look at their meds. All right, so look at the patient history too. I always say, if you hear hoofbeats, think horses, not zebras, right? If you have a person who had a UTI 6 months ago, a UTI 3 months ago, and now they're complaining of dysuria, lower UTI symptoms, chances are they have a UTI. So take that into account. There are some other diagnostics that sometimes go along with especially recurrent UTIs. Those might be like an intravenous pyelogram to check the kidney function and how the medication, or not medication, but the urine is being made. Checking a cystoscopy or a cystogram, taking a look to make sure there's no defects in the bladder or that there's no vesicoureteral reflux. All right, so let's move along over to prioritizing hypothesis. So what's the worst that happens? Somebody gets a UTI, what's the worst? They could die, absolutely. Urosepsis, it's a big problem. If we don't treat the UTI, they could get urosepsis. And then some smaller things, of course, would be pain, impaired urinary system function, but we don't want our patients to get septic and die. So what are our solutions and how are we going to take action on this? Well, solutions really is the relief of symptoms. We don't want the infection to spread. We want no upper UTI if it's in the lower. We want no recurrence. So how do we get them there? Well, it starts with good assessment, our urine culture and sensitivity, knowing how to do a clean catch, which is a skill that most nurses know, but they have to make sure they are doing it correctly. And not everybody is eligible to do a clean catch. If you have somebody who is confused, disoriented, non-compliant, whether they're unable to because of functional or sensory limitations, they can't give you a clean catch. So if that's the case, then you have a responsibility to go back to the doctor and talk to them about what's a better way to get that urine. All right, so let's talk about some prevention, adequate fluids, because that prevents urine stasis, so about 3 liters a day. And if it's not contraindicated, people with UTI should be on some increased hydration. Antibiotics are given. Most uncomplicated UTIs, we treat them for 3 days with antibiotics. And sometimes even without the culture and sensitivity, they'll just give them like some Cipro for 3 days. Because of the pain, sometimes we give pyridium, so that's a medication to know. A big thing is that pyridium causes changes in the color of the urine, which can be surprising to the patient, so we want to let them know about that reddish change to the urine. Antibiotics definitely need to be taken until their completion. Remember, uncomplicated UTIs, we treat them about 3 days. But recurrent, it's the antibiotic for 7 to 14 days. The patient needs to be taught good toileting hygiene. We want them to empty their bladder completely and frequently. Avoiding constipation can help keep that urine flowing. They should void every 3 to 4 hours to prevent a UTI. In the hospital, we want to prevent catheter-associated UTI, so what does that look like for nurses? That looks like gentle pushback on doctors who order catheters to be inserted for really no good reason. It looks like being a good steward and making sure that Foley catheters are removed as early as possible, using hand hygiene and aseptic technique. So other things we can do, the patient is uncomfortable, we can use heating pads and warmth. And I guess that's really about it. I mean, some people that are listening to this have had UTIs. You know how painful they can be. All right, so some medications to know. So I want you to look at these medications because as nurses, these are very, very common medications that are used, and you're responsible to know how to give these meds, certain things about them. So I would suggest that you look at some of the most common antibiotics and know some things about them. And no, I'm not going to go into them all throughout this the UTI lecture because you should have pharmacology, and if you're not up to date on these meds, I want you to go look them up and write them on some cards or know them. All right, so Bactrim, trimethoprim, sulfamethoxazole. can never say it right, but it's Bactrim. It is a very common antibiotic that's used. Nitrofurantoin, which is macrodantin and macrobid. Ampicillin, amoxicillin, the cephalosporins. Fluoroquinolones like Cipro. Fluconazole, which is used here and there. Pyridium, and glycophosphates. So fluoroquinolones we generally use for more complicated UTIs, but you may see them in the others. All right, so people who have frequent UTIs, sometimes we need suppression therapy, and we might do that with like a daily antibiotic. You see people taking cranberry, things that acidify the urine. And I guess that's pretty much where we will end UTI, but I want to take a little bit of a deeper dive now into pyelonephritis because that's an important thing to consider. So pyelonephritis, we're going to open up the concept map, and you can see that here that pyelonephritis is the old name was a kidney infection, right? So it's considered a UTI, but this is a very special one. Pyelonephritis is inflammation of the renal parenchyma and the collecting system. One of the major risk factors to developing pyelonephritis, believe it or not, is pregnancy. But basically, usually acute pyelonephritis begins with the colonization of the lower urinary tract with bacteria. As it moves up, eventually comes to the renal area, and acute pyelonephritis can lead to chronic. So it's very important that we treat the acute pyelonephritis so that we don't end up with kidney damage. So what does a person look like who has pyelonephritis? Fever and chills. The fever can be quite high. My sister actually was just discharged from the hospital today. She had pyelonephritis sepsis, and she's a young person. She's 45, so it's kind of out of nowhere with this, but she definitely had fever, chills, nausea. I mean, high fever, 104.5, malaise, flank pain, and her flank pain went in, and she said it almost felt like it was on top of her hip. So dysuria, urgency, frequency. And then here's a little star asterisk, costovertebral angle tenderness. In your textbook, it tells you how to test for that. That's an important skill as a nurse. Once we know that we have CVA tenderness, that tells us that we are dealing with a problem with the kidney, and if we don't act quickly, that the person can lose their kidney function, and they can become septic very easy. Those who've had recurrent or recent UTIs are at risk. Even people who've had, they have sore throats and fevers because they have bacterial infection. And remember, chronic pyelonephritis leads to scarring and loss of renal function, which can land the patient on dialysis. So how is it diagnosed? The urinalysis, which would show bacteria, hematuria, pyuria, white blood cells. The culture and sensitivity. A person with acute pyelonephritis is ill, so when they show up, they're usually pretty septic looking, so they often will draw the urine and the blood cultures at the same time. We want to check the renal function, checking the GFR, checking BUN, creatinine. CT scan can show us what's going on and can show the telltale signs of pyelonephritis, including like fat stranding and the inflammation. Ultrasound is potential, not used that often, but it's something we can use to look for structural abnormalities. And then, of course, CBC with differential. Oh, and to mention, too, the ultrasound can show hydronephrosis if that's there. So, prioritizing the hypothesis. Remember, urosepsis is a major complication. That's why if somebody has a bladder infection, we want to make sure that we treat that early and completely to prevent this moving up and becoming pyelonephritis. And it can also lead to altered urinary elimination. So what are the solutions? What do we want? Somebody with pyelonephritis, we want normal renal function, normal temperature, pain relief, no complications, no recurrence, right? We want to prevent end-stage renal disease. So we're going to separate patients into either mild or severe. So mild, these people can generally be treated as an outpatient or a very short stay. And the treatment for that is fluids, right? We want to be able to get those kidneys flushed with fluid, flush the bacteria through NSAIDs, antibiotics, antipyretics. So if we have severe, well, let me back up there. So antibiotics, we do a broad spectrum, and then they narrow it down by culture track. It's anywhere from 5 days to 2 weeks worth of antibiotics. Now, severe pyelonephritis, the patient is definitely hospitalized. They need a longer course of IV antibiotics, and then they switch over to oral once tolerated. Now, if a person relapses, then they're going to have to go on 6 weeks worth of antibiotic. So in pyelonephritis, we're always concerned about the risk for sepsis, so we need to be watching the patient's blood pressure, the function of their other organs, their constitutional symptoms, neural status. This is very, very important. And need to monitor for end-stage renal disease, right? And with pyelonephritis, we often will need follow-up cultures because we want to make sure that everything is completely taken care of. So under medications, I want you to refer back to what we already talked about with UTIs, because pyelonephritis, by definition, is a form of UTI, but it's very special. It gets its own page. All right, guys, so that's urinary tract infections. Thank you very much.